Steffen, hi, and thank you so much for joining a discussion on Faces of Digital Health. You come from the Health Data Lab at the German Federal Institute for Drugs and Medical Devices. And today we're going to talk a little bit more about healthcare data in Germany, data gathering, data reuse, digital twins, and synthetic data, which is especially interesting in light of the fact that your center is supposed to start accepting applications for data use this year. But more about that later. Let's first start with a very basic question. So, how does healthcare data gathering look like in Germany, given that the country is fragmented? You have 16 federal states. So, how does data gathering look like on the national level?
That is an issue. The federal nature of the German state, that's always an obstacle. In our case, it's even worse because we are mostly using data from statutory health insurance companies, and that's 95 different companies in Germany. And if you want to gather data from all 95, that can be quite an extensive process. So that is one challenge that we are overcoming with the Health Data Lab. That we are gathering the data from all 95 statutory health insurances, and then we have this data set in one place.
If we go back in history just a little bit, so we set the scene a little bit better. Roughly 10 years ago, I remember a German friend saying to me that in Germany, the national sport isn't football, it's data protection. So can you maybe just explain a little bit how this whole data gathering that you mentioned looks like? So the national insurance companies, have you always collected data from them? Is this something new? Were they reluctant to share the data? So everything that happened, say, in the last 10 years, just so we have a better understanding.
Yeah, data protection is always top of mind in Germany, I would say, which is not bad. We are not gathering data that would otherwise not been collected. What we do is called secondary use of health data. So that's data that's collected for other purposes. In our case, it's mostly claims data, so data that is collected with insurance claims processes. And so this data is there and has been collected on a national level since more than 10 years, actually, but has not been used for research purposes. And that was the starting point for the Health Data Lab or its predecessor, where research said, we want to use this data. This is really, we have great coverage. 90% of the German population have a statutory health insurance, and this data is there. It's collected on a national level, and we want to use it for science. And so this data has always been there. We just collect it from the statutory health insurance companies. The data is standardized, so the data generating process is the same in all of the 95 companies. We just need to gather it in a central place, and we do so in a pseudonymized way, but we will get into that, I guess. As I said, data protection is always top of mind in Germany.
Yeah. I think it's great that you basically mentioned that the data that you're gathering is related to claims, because oftentimes when we talk about secondary use of data, it's a very general thing to say, secondary use of data. And in the previous episode, I spoke with Fidelia Caschini, who recently published a book on secondary use of data. And she starts her book by differentiating between different data types. So genomics data, processing data, data from electronic healthcare records. There's like 9 categories. So it's good to be clear when we are talking about this. So it's just the claims data in your case.
Yeah, that's not entirely correct. At least it is for now. But starting next year, we will receive also the data from the electronic health records from the German population. This is just starting now. So the electronic health records are not have not been possible for quite some time, and the process of implementing the EHR has been very slow. It has now been changed to an opt-out, and I think the opt-out process is now live. So every German person who does not object will get an electronic health record. And starting off next year, we will receive pseudonymized data from the electronic health records as well. So we will have both data sets from the statutory health insurance, the claims data for secondary use, and we will also have EHR data for secondary use as well. And those will come to us already linked. So we already know that the data set from the health insurance matches which data set from the electronic health record. So those can be analyzed in a combined way.
You mentioned that 95%, I think, of the population is insured through national health insurance companies. What's the percentage of electronic healthcare data that you expect to have, and how quickly do you think that data is going to grow, given that I'm assuming that, there's still a lot of interoperability and other issues that need to be solved for all the institutions to send the information to the national platform. So it's gonna take a while to actually get data from all the institutions.
Yeah, it's I think the adoption is growing on both sides. So we need the acceptance in the public eye. So that is starting to grow. As I said, it has been changed to opt out. So usage of EHRs will grow. And on the other side, the implementation of the technical side is also something that we are approaching in an agile way. So we have one data set which is cleared for research so far, which is an electronic medical record. And there will be others that are in the pipeline of being implemented next year then. There's quite some data which still need to be structured, be transformed in an interoperable format and stuff like that. So you're completely right. It's still a long way to go, but we're making the first steps now.
Yeah, it's from patient summaries to vaccines, lab results, and different types of data, right?
Yeah, exactly. Yeah.
There's a lot of things that can be done even with claims data. For example, things like looking at patient similarity metrics that can be used for precision medicine or prediction, or designing preventative programs based on patient characteristic. What are you already doing in terms of analysis of data that you're gathering? What kind of research have you done so far? What kind of was most interesting to you?
To me, I mean, I find quite a lot very interesting. I'm a scientist by heart. Right now, I'm leading the implementation of the health data lab. So there's quite some topics I'm very interested in. I think this larger data set offers itself for quite some for different research avenues. I would say maybe I can emphasize one or two. One is for rare diseases. So if you have rare diseases, you have a lot of trouble to actually register enough patients in registries. If we have a 74 million wide database, so 74 million individuals who all can have rare disease. So this is quite a good basis for research on rare diseases. Or let's say orphan drugs, so drugs that can only be applied in very niche applications. You also need a wider basis for that, so this is something that cannot be done on smaller data sets. So this is something I want to emphasize, because we have this huge data set. The details, the level of detail is not as great as we would like as researchers, because it's claims data in the end. But its biggest strength is that we cover 90% of the population, and the 74 million is quite an asset.
Mm-hmm. Are there any findings that you can mention already of what you found out in terms of just looking at this data? What kind of research are you doing?
Yeah, actually, the Health Data Lab itself does not perform research in its own accord. Our mission is mainly offering data for research. So we are always looking for ways to open new avenues of research possibilities. So that is something that we are looking into. But we are not conducting medical research on our own. We are hoping that the scientific community will pick up on the possibilities that we offer here. But I have no worries. So there's,
Yeah.
I mean, it's an attractive data set, and researchers will be interested.
Absolutely. That's kind of also the high expectation for the European health data space. The idea that we're going to create this huge data lake that can then be used for research. But then if we dig a little bit deeper, the question is who can access the data and under which conditions. I mentioned in the beginning that you are supposed to start accepting applications for data use that the Health Data Lab is gathering in first half of 2025. So where are you with that, those
Yeah.
plans?
So we are actually we will probably start in summer for application and data processing as well. So that's a very near future.
Who will be able to apply? Is it just medical universities? Is it also the industry? What are the limitations and also possibilities with data use?
Yeah, basically it's like the GDPR says, it only depends on the purpose. So everybody can apply if the purpose he or she has for data use actually is conform with one of the allowed purposes. So it's medical research is one of the purposes, but it can also be epidemiology or also like improving the healthcare system in Germany in any way, I would say.
Mm-hmm. So basically, if you're a startup that has an idea on how to improve scheduling in hospitals or I don't know, creating a preventative measure in cardiovascular disease prevention, they could access the data.
Yeah, exactly. So it's basically very free. I mean, the purposes have been defined by the German Parliament, so that is not something that we have come up with. So the German Parliament has decided which purposes are worth it to actually put the data to use, put the data into the health data lab, which will then offers it in the secure processing environment. And so we are just checking if an applicant has the analysis idea is in some of the allowed purposes. Exactly.
Mm-hmm.
Yeah.
Mm-hmm. Can you give me an example of who definitely couldn't access the data?
I mean, if you're a company, let's say, and if you were looking into how you can improve on your distribution of cigarettes, let's say. So that's actually two forbidden purposes. So you cannot do market access research. That's forbidden. And the second forbidden purpose is that developing products that actually harm people is also forbidden.
Mm-hmm.
So
Okay.
these are explicitly forbidden purposes, but I mean generally everything that's in that's improving the public health is basically allowed. Yeah, you could say that.
Mm-hmm. When you mentioned earlier that it could be really useful to have these data lakes in, for example, even to address things like rare diseases, the immediate thought that I had was the applications in pharma and drug development. So I can imagine that it would be very useful to find new solutions for very targeted groups. But then, what about the reverse path, actually getting these solutions to those rare patients, because the same way that it's difficult to get the data for rare patients, it's also really difficult for them to find the solutions, if you know what I mean. So especially if we escalate that on the European level, if you're from a really small country, there might be somebody doing research on your specific rare disease in a different country, and you're not going to know unless the clinician that you get in contact with knows that. So how do you see that ethical dilemma, that in some cases it would make sense to enable that backwards de-anonymization to reach vulnerable populations?
Yeah, I see where you're getting at. I mean, our pseudonymization is actually a one-way street. So we cannot deep pseudonymize even if we wanted to. So we are working with a third party. So that's not possible for us. So if we have any findings, we cannot go back to patients actually. So so that is something that is not possible. But of course, you can develop in our data, you can develop algorithms, especially for people with rare diseases. Sometimes they really suffer quite some years before they get a correct diagnosis. And if you see patterns before the actual diagnosis, you can find these patterns and then apply them to not pseudonymized data, like the statutory health insurance companies, for example. They are now allowed to actually search for those kind of patterns, and then they can then contact the patients. So it's not impossible, but there's just not a direct route. But we can do the science in the health data lab, and then you can go to the patients themselves.
Since we're talking about rare diseases where you have the small data problem, not the big data problem, how do you see the potential of synthetic data in this sense? And it would be good maybe if we start with an explanation. What's the difference between real world data, clinical trials data, and then synthetic data in digital twins? Because I think it's good to just understand those things first before we continue.
Yeah, all right. Maybe I will start with real world data. So I would define real world data as all kinds of health data that is collected in a real world setting, as opposed in a controlled setting. So every randomized controlled trial is a control setting. So you have specific conditions, a specific set of patients who are included in the trial, etc. So real world data is everything that happens in the real world. So patients get treatments that are not supposed to get these treatments, and like everything that you can imagine actually happens, especially if you have a population of 74 million. Every kind of combination that you can think of will actually happen. So that's not visible in clinical trials because everything's very controlled there. So if you want information about the real world, you need to use real world data. Now you could say you have data of 74 million Germans. You don't need synthetic data. Well, I wouldn't say that. So we are quite big fans of synthetic data for various reasons, I would say. The first reason is privacy. So we want to give researchers only access to data when they need it. So there's quite some situations when it's still exploratory phase, or researchers are still in the, let's say, finalizing their analysis code phase. So this is a phase where we want to offer synthetic data. So we offer real data when it's needed, but only then. And we want to offer sensible, or let's say high fidelity synthetic data as early as possible. For researchers. Research can be a quite iterative process, and we want to offer data as early as possible, but that needs to be very non-sensible data, or in other words, synthetic data. So that's one purpose for which you could use synthetic data. And other purposes are if you have a bias in your data. So we have a very representative data set, but we are lacking 10% of the German population who are privately insured, for example. And if you want to draw conclusions independent of that, you can sample those data. So that's bias correction is always a good use for data. Or market access applications. There's more and more applications that are relying on synthetic study arms. So you have one study arm who gets the treatment, the other one who has synthetic controls or historic controls. The names vary a little bit. And you have to be very careful what kind of methodology that you're using there. And I think it's good that we are building up the knowledge, the expertise within the BfArM and the Health Data Lab, that we can actually know with methodology is actually working, or what are the limitations of methodology. That's quite important here.
Mm-hmm. I love that you mentioned that, because it's like wondering what's the best recipe to cook, this type of data. So if you had to explain to a 5-year-old, how do you create synthetic data, what would you say? Like, how do you make up basically representatives of people that don't exist and make sure that that's useful for research?
Yeah, it's kind of this game for preschool kids where you can change several body parts of pictures, right? So you exchange the hats of the people and the trousers of the person. So this is something that you can do. You kind of mix up parts of individual records and mix them up in such a way that like the original people are not recognizable anymore, but the results are still realistic people, let's say. And what you consider realistic, it's of course depends on what kind of application that you have in mind. If you have a very sophisticated analysis code, then the standards that you need to have for the synthetic data are very high. If you just want to measure what is the occurrence of diabetes in your data set, then you need just a basic synthetic data set is sufficient, I would say.
Okay. You said that you are very optimistic about the use of synthetic data, but even when we spoke before this call, you mentioned that some companies or researchers are not that excited about synthetic data, because even if they do find out something or develop an algorithm based on synthetic data, they still need to validate their solutions on real world data. So it's kind of like adding a step in their process instead of using real world data from the starting point. So how do you see that challenge and basically the whole development and usability of synthetic data?
Yeah, I mean, it all comes down to trust, I would say, as in other parts of healthcare data. It's basically you need trust everywhere, and you also need trust in the synthetic data itself. So you need to have synthetic data which the researcher trusts. So if you have very high trust, then basically researchers could go out and publish their conclusions from the synthetic data itself. I think we're not there yet. I think we're still in the phase where there's still some skeptics with regard to synthetic data. So what researchers do is actually they want to go to the original data set and check if the conclusions are still the same on the original data as they are on the synthetic data. So we're still in this phase. But on the other hand, if you can do, let's say, 99% of the research process with synthetic data and only use original data for the last percent, for the final run, for the final results, then you have in 99% of your time as a researcher, you have much more freedom with how you can use data, where you can use the data, what you can do the data with, and only for the last percent you have to go into the high security area, I would say. So this actually frees researchers quite a bit, and I think that is the message that we need to bring across right now.
Mm-hmm. How do you view Europe in terms of its potential for future AI development and the development of synthetic data and the secondary use of data which you're trying to develop with the help of EHDS? If I'm not mistaken, you're also participating in the Real for Edge European project, which aims to promote the use of real-world data to support regulatory decisions about medicines and AI development. So, Europe is often seen as conservative, as very hard to get to data. So, how do you see this whole, situation, perception, realistic options?
The challenges are there, obviously. I mean, we still have some way to go with the European health data space, but I think the possibilities are also huge. I mean, we have quite some big countries. If you would add for example, the French and the German databases, then you already have datasets that are comparable with the biggest datasets that are available so far worldwide, I would say. But there's still some regulatory challenges that need to be overcome. And that's what we're doing with the EHDS. But if we get this on track, then we have a data set that is very, very attractive, where the data are collected, or the data generation processes is very well understood in each country. That is not always the case with, let's say, commercial databases, which are sometimes have big numbers, but if you look into the detail, it's kind of looks like if unequal parts have been glued together. So this is something that which is on the opportunity side, and I think that is something that we need to focus on. This is the goal that we're working towards with the EHDS.
Mm-hmm. One thing is also very interesting to me when we talk about, data access and also regulation. As we mentioned, the Health Data Lab is inside BfArM, and in light of the dismantling of FDA that we see in the US, I'm kind of wondering if this is going to mean that the European Medicines Agency or the European agencies are going to be maybe expected to take on a bit, even a higher level of rigor when assessing solutions. How do you see that in terms of, from the data perspective?
Oh, I don't know if there's a special data perspective. I mean, I'm a patient myself. I don't have any fears if the EMA has approved of a medicine. I'm quite sure if that is safe to use, independent of the existence of an FDA or not. I would say.
Yeah.
So I have no worries there. For the data perspective, I'm not quite sure what the impact will be, actually. I think we have to wait and see.
Yeah, absolutely. It's definitely too soon to say. Where do you see the potential challenges or roadblocks to successful use or the scaling of synthetic data, or even digital twins? Is it regulation? Is it the methodology? Should regulatory organs and basically data processing regulators be the ones that are basically in charge of the data processing? So where do you see, how could we speed up the potential of synthetic data in essence?
I think there's challenges on all sides, to be honest. There's the regulatory side, so there's dependent on how the synthetic data has been generated. For example, if you use large language model or something, some black box model to generate synthetic data, how can you be sure that no individual information of individual patients has leaked into the synthetic data set? So that is quite an issue, and there's still some effort that needs to be put into that. So there's an effort on this side. Then we have the challenge to actually generate good synthetic data. So that is what I meant. We need high fidelity synthetic data. So we need data that actually convinces the researchers to use it. So if the quality is bad, researchers won't switch from original data to synthetic data, no matter how much easier it will be to use. The quality needs to be there. And this touches the third part of the challenge, which is acceptance. So as I said, we need to build acceptance in the research community that synthetic data can be an interesting tool or an interesting algorithm to use, and can be also help you with maybe 90 or even more % of your research.
Mm-hmm. What would convince you as a researcher to use a specific synthetic data set? So how do you differentiate between the different qualities of data sets? Do they have any specific marks or information that you can see, like the size of the data or how it was modeled? Like what are the criteria for assessment for researchers?
There's quite a lot of metrics. I think time does not allow to elaborate on this. So it's definitely worth checking the data on the metrics. And maybe another thing is transparency. So if you can understand how the data has been generated, you're much more likely to use the data, because then you have an idea of the limitations. If you know how it has been generated, you know what the limitations are, what the possibilities are, and then you're maybe more at ease using those kind of data. If it's a black box algorithm and you don't know how it has been generated and where the limitations are, then you're not very likely to use it.
Yeah. It's the whole debate also around AI, and should it be open? Should the algorithms be open? To which degree?
It can be. It can be very open. It can be open source. It can also be explainable AI, which is also an interesting avenue, which I'm not an expert in, but there's interesting options out there.
As we mentioned quite a few times by now, the Health Data Lab is going to start accepting applications for data use in 2025. Can you just shortly say who can apply? Can any researcher from any country in Europe or even beyond apply? Do you have any information on the size of the data set, apart from saying it's basically 95% of the population and it's mostly claims data? So any useful information that interested researchers might find useful?
Yeah. So basically, I would say every European can apply. So basically from every country where the GDPR is the basis of your application. So that is the precise definition. It all depends on the purpose. That's also from GDPR. It does not depend on the person or the company or on if the HDL likes this person or not. So you just have to apply for the right purpose, and then you get access to the data. There's also no ethics committee involved. So we are deciding on our own if the application is valid or not. And then you get access to the data. You get access to the data in our secure processing environment. So this, you do not need to travel to Germany. You can access it from other countries as well. So it's a virtual environment where you can access data. And if you're done with your analysis, you can lift your finger and say, I want the results. And then we are checking the data if there's any information about individual persons remaining. And if this is not the case, then you can download the data. So this is the process, basically.
So you can work on the data in the virtual environment and just get the results, or can you actually also download the data?
No. That's the whole purpose of the secure processing environment. You cannot download the data. We are offering what we call a public use file that's already online. So if you want to play around with our kind of data, you can do so. Just go to our website, download the data, play around with it as you wish. That's very anonymous. But the whole process is that the whole idea behind the process is that you get access only to the data that you need for your application. So it's a data minimization approach here. And this kind of data that you get in a secure processing environment, where you can finalize your analysis script, and then it can run on the full data in our backend. So in all of those steps, you cannot download any data. Only at the end, if you say, I'm done, the results look nice, I want to download them, then we are checking in a manual process if that's okay. If we need to ensure that no information about individuals is contained, and then you can download it.
Do you already have any expectations in terms of the timelines for approval of applications, and also how is access going to be managed? Is it going to be a time limit? Is it going to be a one-time access, a 10-time access? And also, are there going to be any costs associated to that? We know that in Finland, FinData, which is basically a similar authority that enables access to the Finnish data, has very specific fees based on the entity that is trying to access the data.
Yeah, so the feeing system is actually defined by law. So this is maybe too complicated to explain it here, but you can check it online, and we will also bring it on our website in maybe more understandable terms. So there's a fee involved. The access works such that you can apply for data use, and in hopefully faster than 3 months, you get access to the data. So 3 months is the limit that we have by law. We're required by law to provide data access faster. And if there's like the first application will get access much faster, because the process internally at us is not so complicated, but we don't know how many applications there will be. So,
Absolutely.
right? So 3 months is the maximum, and you will get data sooner. Then you have access to the secure processing environment, and then you can use it for several days. I think it's up to 30 days, and you don't need to analyze it in a row. So you can take 3 days, then you can take a month discussing with your collaborators, and you can come back to the secure processing environment and continue your analysis. So that is possible. And it's also depending on how long you're using our systems, on how big the fee is in the end. So we're hoping that we need to we wanted to provide maximum flexibility for researchers. So there will be researchers who are very prepared, who can, I don't know, run their analysis in the first couple of days. And there will be groups which need to discuss every second day. And it's not up to us. I think it's everything is possible, basically.
Yeah. So a short piece of advice would be come prepared as much as possible with your hypotheses and assumptions. And then the bill will depend on basically also that. But like research is always to a degree unpredictable. And you don't know where it's going to take you.
Yes, that we are well aware of that. That was how we designed the system in the first place, to be to allow for the, I would say, maximum iterativity, is that a word? Of the research process, because as I said, I'm a researcher myself. Sometimes it also does not depend on the person. Sometimes you're very prepared, you know exactly what you're doing, you're going start to finish in 1 or 2 days. That's fine. And in other research projects, you're kind of stuck. You need to discuss with collaborators, you need to bring in experts. That's just how it is.
Yeah. And you definitely also don't want to create too much work for yourself as the one deciding who gets access or not, because if the access is too limited, people would keep coming to you, which means that, the number of applications would rise even more. Well, we are gonna see where the interest is gonna go, and also what the results are going to be. For today, Stefan, thank you so much for sharing all the information, and we will definitely keep up with the progress and when the date for the applications opens.
Yeah, thank you very much for having me.